Menendez with White Plume. Thank you everybody for joining us today. I hope that this will be helpful for you. What we're going to be doing today is looking at some of the ICD-10 risks that are still ahead of us as we fully transition to ICD-10 in 2016. What we're going to do over the next 45, 50 minutes, let me give you just a quick agenda for today. The first thing that I want to do is address the question, why in the world are we still talking about ICD-10? Many of you may have colleagues, may have physicians in your practices, in your organizations, with this question in mind. They may say, I thought that was something that we did last year. I thought that ICD-10 was over and done with in 2015. Why are we still talking about that? I'm going to address that head on before we even begin. Then we'll jump in and take a look at what some of the short-term risks are for ICD-10, what some of the long-term risks are for ICD-10, because you have both of those. Those exist both in the short term and in the long term, and we're going to talk about what those risks are. The other thing that we're going to do is specifically spend time focusing on the two, what I think are the two biggest risks. Number one is looking at physician productivity. If your doctors aren't taking care of patients, nobody is. If your doctors aren't generating revenue for the practice, nobody is. And at the end of the day, if your doctors aren't happy, nobody else in the practice is. So we want to make sure that you have a good plan in place to protect your doctor's productivity. Now, the second piece of this is equally important, and that is the revenue cycle. You have to be able to turn those patient encounters into cash, and you have to have the right codes to do that. And we're going to talk through that process, where some of the revenue cycle risks are in 2016 as well, and how to mitigate some of those risks. As I mentioned before, I'll make sure that we leave plenty of time for questions and answers at the end. So for those of you just joining us, welcome. Feel free to use the questions panel with any questions that you may have as we go. So the first question, why are we still talking about ICD-10 in 2016? If you rewind a year, what a lot of people compared ICD-10 to the prevailing metaphor in the industry was Y2K. This is the Y2K of healthcare, and there are a lot of parallels, right? It was a one-day conversion. There was significant risk, right? If you didn't do ICD-10 or didn't do it well, your cash flow would stop overnight. And there was a lot of concern. You remember consultants were recommending getting a line of credit, making sure that you had 4 to 5 months of operating expenses, so that if there was a nationwide problem with reimbursement, with claims being paid, that you'd still have money to pay the bills and pay your staff, right? That was the prevailing metaphor. And a lot of people really bought into that and looked back after October 1st and said, you know what, this was really a non-event, just like Y2K. But I think that's a dangerous metaphor. I think it's inaccurate, and I think it misses the boat on what we're really trying to do with the new code set. I think a better metaphor may be the birth of a child, right? If you remember having your first child, there's a lot that goes into that. There's a lot of preparation and you know, buying a crib and buying all of the baby gear that goes along with that. But when you have your first child, it's not the 9 months leading up to the due date that are the most important. Most of the hard work comes after the baby is born, right? That's where the hard work of parenting takes place. You know, this is my wife, our first child, born almost 7 years ago now, and you can see a lot of the hard work of parenting happens after the fact, not before, right? And a lot's changed over the past 6 years. A lot will change in your organization as you continue to roll out ICD-10 more fully. We used ICD-9 for 30 years, and sometimes it works really, really well, and there are some times when it's really, really messy. So I think the prevailing metaphor for ICD-10 really should be birthing a child, not Y2K. I think most of the hard work of ICD-10 is ahead of us, not behind us. Now, anecdotally, that's helpful, but what does the data say? Let me share some information with you that comes from CMS. Medicare leading up to ICD-10 predicted that denials would double or triple as a result of ICD-10. That's 100 to 200% increase in denials as a result of ICD-10. This is what a lot of people were worried about, right? This is the doomsday scenario for many, many practices. So what happened? When we look at the data of what has happened over the last 6 months, what we'll see is that denials have not increased at all. They haven't moved 1 inch. You know, here is the Medicare data that was released that compared the historical baseline, that is what was happening with claims prior to October 1st, and what happened in the 4th quarter of last year. And you can see when you compare these figures on the top line, you'll see the claim volume hasn't changed, right? Providers are still submitting 4.6 million claims per day to Medicare for reimbursement. And then if you look down at the bottom line, what you'll see is total claims denied were right at 10%, the historical average, and actually decreased slightly, although it's statistically insignificant, to 9.9% in the 4th quarter of 2015. So the claim volume has stayed the same, the denial rate has stayed the same. But that's not what the government was predicting. That's not what Medicare expected to happen. So why were they so wrong? Or how do you explain the discrepancy between what they predicted would happen and what actually happened? A few possible explanations let's explore quickly. The first is maybe ICD-10 was not as hard as everybody thought it was going to be. Maybe this was all blown out of proportion. Now, I think that's an unlikely explanation because we do know that ICD-10 is very, very different than ICD-9. Many, many, many more codes, 69,000 compared to 16,000. Much more specific, much more granular in the ICD-10 code set. A lot of people spent a lot of hours preparing your organization to be successful in ICD-10. Consultants, coders, billers, vendors, your providers, your management team. I think this explanation really shortchanges the amount of effort that went in to making October 1st a success. Another possible explanation is maybe that the data submitted by the provider community is much, much better than what the government expected. Maybe all of our providers spent nights and weekends last year memorizing the new ICD-10 codes. And the quality of the data that they submitted was much, much better than what Medicare expected to receive. And again, that may be true for some practices. Maybe it's true for some of your practices. But in general, I don't think that can explain the nationwide phenomenon that the denial rate has not moved at all. I think the most likely explanation is that we have not seen the real impact of ICD-10 yet. That means that most of the changes are ahead of us, not behind us. And I'll explain why. We'll walk through that. One of the first things we'll need to do is kind of look back at what happened in 2015 and then look forward to some of the predictions of 2016 to kind of see why we haven't seen that impact yet and what that will look like for us in the near future. So first, the good news of what happened in 2015 when we take a look back. The best news for everyone is that we survived October 1st. Many of you probably remember what it was like the night of September 30th. You've dotted all of your I's, you've crossed all of your T's, and now you're waiting to see the results of your plan. And for most people, their stakeholders were prepared. The payer community, the provider community, the vendor community, the government, everybody was prepared, and we didn't have a nationwide meltdown. The claims process was largely successful. There were a few isolated pockets where LCDs weren't updated correctly, right? But the payers, for the most part, corrected those errors quickly, right? Patient care did not suffer. There was some concern for that leading up to ICD-10, right? And maybe the best part of all of this was the CMS announcement in July that they would not deny claims for lack of specificity. Do you remember this? This was the 12-month grace period that they extended. I'm going to talk about that a little bit more in detail. But many industry thought leaders attribute the success of ICD-10 thus far to the decision by Medicare to not deny these claims yet. That's the good news of what happened in 2015. What about the bad news? The bad news of what happened in 2015, again, I'm going to start with the exact same point, that CMS delayed those denial rates. And the reason why I say that's bad news is for many people, they're not taking advantage of the grace period. For many people, they've just moved on and said, you know what, I'm getting my claims paid, so I must be doing a great job with this. And it allows some suboptimal workflows to have successful outcomes. And unless you're really paying attention, that's something that can go undetected for quite some time. And it reinforces some bad habits, some shortcuts that people are taking to try to make this as easy as possible, which makes a lot of sense. But if you're not prepared when the game changes, that makes it very difficult. And for many organizations, their leadership has moved on, right? Their leadership is not focused on this. There are other fires to fight, other problems to solve, and they're not being careful to watch out for this. And that's one of the recommendations that I would make is you've got to keep at least one eye on this so it doesn't catch you off guard, so that you've got a plan in place. So looking a little bit into greater detail about what did CMS do, what happened in July. It was a joint press release, right after the 4th of July. They like to put these kinds of bulletins out right around holiday weekends oftentimes. And CMS and the AMA had a joint press release. Remember, the AMA had been a vocal opponent of ICD-10. They had done everything that they could to delay or stall or kill ICD-10 if at all possible. AMA finally surrendered, but in return they asked for CMS to not deny those claims for lack of specificity. What Medicare said is, as long as you're in the same code family, and the code family is the first 3 digits of the diagnosis code, as long as you're in the same code family, we're not going to deny that claim. And they extended that to PQRS and the value-based modifier programs as well, right? Now, AMA said that they would stop fighting or opposing ICD-10 and that they would actually work with the government to help physicians prepare. But that's what happened, right? And the biggest piece of this is the first bullet point, that they wouldn't deny those claims before October 1st, 2016, right? So if you heard about the 12-month grace period, this is what they're talking about. All right, and the danger here, in my opinion, is that it gives a lot of people a false sense of security. Right? Go back to October 1st. Me, my team, our company was on pins and needles, waiting to see how our clients were going to do with ICD-10. We'd done all the preparation, and it was time to see what was going to happen on D-Day. And so what we noticed was there were a lot of other vendors, right? Practice management vendors, EHR vendors, and what they were doing was they were tweeting out pictures or issuing press releases from their war rooms saying that they had succeeded, that they had successfully transitioned to ICD-10. And many administrators, many industry watchers said, hold on, not so fast. Let's wait and see what happens as we go through the rest of the month. And I think that was prudent advice, right? And then you waited another week or a week and a half, and you saw the same type of celebrations from the clearinghouses and from the payers, saying we're able to successfully transmit claims. We're able to successfully receive the claim on the payer side. And they were raising the victory banner as well, saying that their organizations had successfully transitioned to ICD-10. But again, you had people saying, hold on, let's wait and see what happens when the claims come back. Are the claims going to get paid? And then by the end of October, when claims were coming back, the process was going through the entire cycle, many people said ICD-10 was a non-event. It wasn't as bad as we expected. We successfully transitioned to ICD-10. And what I think we're seeing in these 3 steps is that data is flowing from the beginning of the process all the way out the door to the payers, and claims are being adjudicated successfully, right? The vendor systems are able to support and accept the longer diagnosis codes. They're able to transmit those out on the claim forms. The clearinghouse is able to take those and pass them along to the payer, who is able to receive them and go through their adjudication process. We've got all of the pipes connected and the data is flowing. But the question that remains to be answered is, how clean is the data that's flowing through those pipes? Is it high quality data, right? Or do we have low quality data flowing through those pipes? And when the payers, Medicare and the commercial carriers, begin to clamp down on that, when they begin to require greater levels of detail, that's when we'll see how well prepared the physician practices and the revenue cycles in those organizations are to deal with ICD-10, right? And what's happened is the PM and EHR vendors have said, we've been successful. If there's a problem downstream, it's not our fault. The clearinghouses and the payers have said, we've been successful. If there's a problem later on downstream, it's not our fault, right? And what that means is a lot of the risk, rightly or wrongly, remains in the physician practice, right? In the provider network. That's where a lot of the risk remains. And so one of the questions that you have to ask yourself is, okay, all of my pipes are well connected, but what about the quality of the data that's running through those pipes? What does that look like? And so I think the important question to ask is, well, what ICD-10 codes are you actually using? You remember the lead up to ICD-10? All of the craziness that people like to make fun of, some of the new codes, right? This was probably my favorite, the one that was probably the most infamous ICD-10 code, this water skis on fire encounter. You know, we have looked at over 6 million coded diagnoses from the fourth quarter of 2015, and I didn't see this code used a single time. It didn't happen. It was never used, right? And we never thought that it was going to be used either, right? A lot of the crazy, ridiculous codes got a lot of the attention in the run-up to ICD-10, but I would tell you that they were a distraction. They made people focus on some of the ridiculous aspects of ICD-10, but they ignored the more dangerous codes, the silent killers. And what I'm talking about here are the unspecified codes. There are many, many unspecified codes with varying degrees of vagueness in the ICD-10 code set. Did you know there's a higher rate of unspecified codes in ICD-10 than there was in ICD-9? Right? Even with all the new levels of detail, we have more unspecified codes in the new code set than we did in the old. So the question is, how frequently are these codes being used? So we looked across the national average to see, you know, what's happening and what does that look like, and how do you know what that looks like in your practice? And I'm going to share some of that data with you. But I want to first talk about what are the risks of using these unspecified codes, right? Because they existed in ICD-9, and there really weren't any negative consequences to using the unspecified codes in ICD-9, right? People used them on cheat sheets. People had memorized some of the unspecified codes, but there were no negative consequences. And that's simply not true in ICD-10. In ICD-10, there's a short-term risk to using the unspecified codes, and there's also a long-term risk. The short-term risk, you'll probably see this in the next 6 to 18 months in your practice if you haven't seen it already. And this is that the claims are going to start being denied. The claims are going to start being denied, and you ask yourself, so why is that going to happen? Well, let's think like the payers for just a minute. Think about this. Why did the payers want to move to ICD-10? Why did they lobby Congress to move forward with ICD-10? Why did they invest millions of dollars rewriting their adjudication algorithms to handle ICD-10? It's because they want the more detailed diagnosis information that's available in ICD-10. They want the more granular data on their insured patient populations. And if the provider community does not give that to them, they're going to start denying the claims. Maybe not today, maybe not tomorrow. We don't know when that's going to happen. Different payers will probably handle that differently, right? Medicare is the only one that has explicitly stated that they would not do this before October 1st, 2016. The other commercial payers have followed suit thus far, but are under no obligation to wait until October 1st to do this. And when they begin denying the claims, you'll see a lot of the things people were worried about on the front end leading up to ICD-10. We'll see increase in denials. We'll see longer AR days, right? We will see coders having to spend additional time researching denials. They'll have questions that go back to the physician, back to the clinical staff, that require additional information that takes away from their time with patients. You know, one example, one place where we've already seen this from some of our clients is in Georgia. Georgia Medicaid has already started denying for unspecified codes. They started this in the fall. And they continue to deny for unspecified codes. And they, in fact, took a fairly aggressive stance and were denying many unspecified codes, even when it was probably an acceptable situation to use an unspecified code. I'll give you one example. Pediatric practice in Savannah, Georgia, one of the codes that they would frequently use was an ICD-10 code for an unspecified fever, right? A patient comes in, you know, it's a child with a fever. It's not so severe that they need to go to the hospital, but it's a fever virus. They're really not going to do much to treat it except send them home and tell them to get plenty of rest and drink plenty of fluids, and it'll run its course. So they use the code for an unspecified fever. They're not going to go through and do the additional test to determine what's causing the fever. It's unnecessary. And Georgia Medicaid was denying that claim because they were using a code that had the word unspecified in the description. They were taking an overly aggressive approach here, right? But you need to be on the lookout for that so that you can make the corrections and use the more specific code when it's appropriate, and when you're using when the denial is inappropriate, that you can fight back against the payers. Because remember, they haven't done this before either. They are learning as they go, and you want to make sure that you're prepared to respond to these. Okay? But I also mentioned there's this long-term risk. And what's the long-term risk of using these unspecified codes? You'll probably see this a bit further out on the horizon, but for many of you, you may start to see this in 2017. It's very, very clear that we are trying to move away from the fee-for-service world into a more value-based reimbursement model. You can call that pay for performance, you can call it pay for quality, pay for outcomes, choose your buzzword, but trying to move away from that fee-for-service model. And in that world, in an outcomes-based world, if it's risk-adjusted, what you're doing is you're looking at the expected outcome for that particular patient compared to the actual outcome for that patient. And in order to maximize your reimbursement or even just keep it flat, you have to be able to show how sick your patients are. You have to be able to use the more specific diagnosis codes, right? So we've seen this from clients who are already participating in an ACO or in Medicare Advantage plans where they're using the HCC codes, right? But even if you're not doing that already, think about what you're doing all day long, every day. You are supplying the payers, both government and private payers, with the data that they will use in your next contract negotiation, right? If you want to be able to prove that your patients are sicker than other patients and show how well your providers are doing to justify an increase in your reimbursement, your payers will be looking at that data. And you need to make sure that you're not giving them the ammunition that they're going to use to turn around and shoot you with. So it's very, very important, right, even if your claims are not getting denied today, to know what codes you're using and what the short-term and long-term risk to using those codes are. I'll share some data with you. We looked at a study that was done. The National Institute of Health makes data available on diagnosis coding, and you look across the country, the national average for how frequently practices use unspecified codes is 31.5%. That means nearly a third of the coded diagnoses are unspecified codes, right? Now that data was available from 2014 and obviously was in ICD-10. I would expect that to be a little bit worse when we start to look at the data in ICD-10, but they have not released that data for 2015 yet. We have looked at that data from our own client base in 2015, and what we've seen is the unspecified rate in the fourth quarter of 2015 for white plume clients was just over 10%. That's nearly 3 times better than the national average, right? And that's interesting and useful, but what you really care about is what is your unspecified rate? How are your providers doing with this, right? That's what I think is really important, and I'll talk to you about how you can do that, some steps that you can go through to find out what that is for your practice. But let me give you just a couple examples of what we've seen, some unspecified codes that get used over and over and over again that are being paid today but are likely to be denied in the near future. I think you'll start to see why this is problematic, right? M19.90, right? Depending on where you get the description from, you may see something very different. You may just see this as OA and think it's a fine code. But when you really look at the diagnosis description, you'll see that it's unspecified osteoarthritis of an unspecified site, right? When you see unspecified multiple times in the description, right, that's a red flag that this may be one that's going to really cause me a problem in the near future. You look this up in the code book, you'll see that there are 95 other ICD-10 codes that are more specific, that might be better options. But this code was being used 11% of the time. And what that means is it's being used a disproportionately higher share than what you would expect, right? If there were 95 codes and they were all being used equally, you'd expect each one to be used about 1.02% of the time. This one's being used 11% of the time, right? And it's unspecified as far as the type of osteoarthritis, meaning is it primary osteoarthritis? Is it secondary osteoarthritis? Is it post-traumatic osteoarthritis, right? What does that look like? It's also unspecified as far as the joint, right? Is this in the shoulder or the knee or the hip or the wrist? It's also unspecified as far as the laterality, right? Are we talking about the left knee or the right knee? Which side of the body is it on? So you can see where you're using this information, you're using this code. The payers are going to start to crack down on that and require a greater level of detail. And some payers may begin that in April, some may begin that in June or July or August. Medicare said that they won't do that before October, but there's no guarantee that the other commercial carriers will do it that the same way. Here's another example. Let's look at a malignant neoplasm of the breast. The most commonly used ICD-10 code, C50.919, is a malignant neoplasm of an unspecified site of the female breast. And again, if you look that up in the code book, you'll see there are 54 other more specific choices that you could be using instead. But the unspecified code is being used on nearly half of the encounters, right? On half of the encounters, you're using an unspecified code. It could be unspecific as far as the site. Is it the upper inner quadrant? Is it lower outer, right? And then which side? Is it the left side or the right side? There's no such thing, right, as a third side of the body. There's no third eye, there's no third hand, there's no third knee. right? We need to be more specific here. We're going to start to have problems both in the short term or in the long term. Last example, let's look at this one. Unspecified otitis media, right? Again, you start to see the pattern here. 80 more specific codes available. Unspecified codes are being used nearly 60% of the time. And again, we need to be more specific on the type. Is it acute otitis media or is it chronic? Is it serous or non-serous? Is it the left ear? Is it the right ear? Is it both ears? Right? You may be using codes like this today. You may be using some of these codes in your practice today. And they're not causing a problem. That's why this is one of those hidden risks. That's why most of the risk is still ahead of us, not behind us, right? From a high-level perspective, think about the workflow process, right? The physician has the encounter with the patient, right? Some data, whether it's captured on a cheat sheet or on a piece of paper or in your EHR, right, or just in a dictated note, is going and made available to the billing and coding team, right? It is either arriving in an automated fashion or a manual fashion, getting into your practice management system, going out the door to the clearinghouse and to the payer. Again, all of those pipes are connected and data is flowing today. Your process looks like it works well. But when the payers start to clamp down, what happens? Right? That's where everything bogs down and we get back up to the top of this process. Our billers and our coders have to stop and deal with the denial. They have to go look for the more specific information. Is it available in the patient's chart? Is it available in the note in the electronic health record? Or do I have to go back and ask the clinical staff additional questions? Was it acute or chronic otitis media? Serous or non-serous? Left ear or right ear, or both? Right? That takes away doctor time, that takes away biller time, and at the end of the day, it slows down your revenue cycle. Right? That's the concern. That's the risk. And when you look at this and you start to examine, trying to quantify what that might look like for your practice, let me share two studies with you briefly. The first one was done by a group based out of Washington, Nachemson Advisors, and they tried to look at what the cost would be for a physician practice to transition to ICD-10. They broke it down to small, medium, and large practices, and that was 3 providers, 10 providers, 100 providers, respectively. So let's take a look at the medium practice, 10 providers. Okay. They also broke down the cost into pre-implementation and post-implementation expenses. The good news here is the pre-implementation expenses are behind you. You've already done that. You've upgraded your systems. You've done your training. You've done your testing. Right? The bad news is the post-implementation expenses are still ahead of us. Right? Look at what they stipulate will be the post-implementation expenses. 2 areas: productivity loss. You know, once you lose that time, you never get it back. And payment disruption, denials coming back from the payers. The post-implementation expenses are larger. The post-implementation expenses are still ahead of us. And the post-implementation expenses you can do something about. Let's take advantage of the extra time that was given to us during this 12-month grace period to try to mitigate some of these risks. Another study that was done that I think is helpful to look at, this one was done by the advisory board. They looked at Canada's transition to ICD-10 and looked at where some of the productivity losses were as a result of ICD-10. And look what they put front and center. Front and center, they put physician productivity loss of 10 to 20%. Right? That is unacceptable. That is completely unacceptable in a physician practice in the United States for an unfunded mandate like ICD-10. You know, let's get underneath those numbers just a little bit and take a look. And what they're saying is you had denials coming back, you had questions coming back from the coding department, to the clinical staff. I need more detail here. Tell me about the type of osteoarthritis, right? Where was the malignant neoplasm? Which breast was it in and which site? Serous or non-serous on the otitis media? In those questions, we're taking, on average, 45 to 90 minutes per provider per day to answer. 45 to 90 minutes per provider per day to answer. And that is completely unacceptable. In a busy physician practice, your doctors do not have that time to spend answering coding questions. That's not what they're best at. That's not what they're trained in. That's not their highest and best use, right? Our doctors did not go to medical school because they wanted to be coders. Even if you cut that number in half and say it's 22 to 45 minutes, where do you find that extra time in the day? Are your doctors going to see fewer patients? No. Most people can't afford to do that. Right? This is not Canada. We're not a single payer system where our physicians are government employees. Our physicians, for the most part, are small business owners. They're paid based on their productivity, based on their volume. So they can't see fewer patients. And I think it's unfair to ask our doctors to spend 22 to 45 minutes per day at the end of their day answering those types of coding questions, right? Rather than going home and spending that time with their family. We have to protect against that. And the good news is we still have time, right? We still have time to examine this risk and put some processes in place to minimize this as much as possible for your providers. Now, it's not just the doctor time. Let's talk about the other two aspects as well, but I think that's obviously the most critical piece. Okay, so number two, on the far left, you see the coder productivity decline, right? The coder productivity decline, you see a significant decrease in the beginning. As they're getting up the learning curve, the productivity decline could be 20 to 50% for our certified coders, right? But they do get some of that back. As they get more experienced with ICD-10 coding, they will get some of that productivity time back, but they never get back to pre-existing levels. They never get back to where they were before, and that's not their fault, right? It's not their fault. It's just that ICD-10 is more complicated than ICD-9 was. It takes longer. It requires more detail. And then you look on the far right, the rework productivity declines. That again matches up with the Knockhamton Advisor study, the Medicare prediction that denials will double or triple. The increase in the denials, increased rejections from the payers will take the revenue cycle team more time, right? So if that's the risk, if that's what people are expecting, how does that correspond to unspecified codes and your unspecified rate? What does that look like? Let's look at an example. And again, this has a lot of data on it, a lot of information, so let me walk it through for you. This assumes a 10-provider practice, and each provider sees, on average, 30 patients a day. So that's 300 encounters for the practice each day. Now, each encounter has 3 ICD-10 codes, 3 diagnosis codes. So that's a total of 900 diagnosis codes for the day for the entire practice. So you can see a 10% unspecified rate. If your payers all began to deny all unspecified codes in one day, would mean 90 new denials for that practice. That is a significant increase from where they are today, right? That is a significant increase from where that practice is today and requires extra labor time, extra time for the providers to answer questions, and will slow down your cash flow, right? Again, in that scenario, if we assume that each of those questions requires greater detail from the provider, And on average, it takes 3 minutes per question for the physician or the clinical staff to read, research, and respond to that question. Right? So 90 denials for the practice. That's 9 each for the providers. 3 minutes per denial is a total of 27 minutes answering coding questions for the provider, for each provider in that practice. So you can see how very quickly you can get yourself into that situation that these studies were pointing towards. And this risk is still ahead of us, not behind us. Again, for a 10-provider practice with a 10% unspecified rate, if you assume that each denial used the medical economics figure of $25 per denial to cost to research and resubmit, that's nearly $2,000 of cash flow risk per day for a 10-provider practice. That is significant. And obviously, if your unspecified rate is higher, your risk in that scenario is higher as well. Now, again, these are all forward-looking numbers. We don't have good, hard quality data on this yet because the payers have not cracked down yet. Right? This risk is still ahead of us. And we assumed 10 providers, 30 patients per day, 3 diagnoses per encounter per patient. Your numbers may be a little bit different, but just to give you an idea of what we're looking at here. Okay? So how do I apply this in my practice in 2016? What are the questions that I need to be asking myself? I think the first one is, how at risk is my practice? Right? If this is what the future is going to look like, how at risk is my practice? What are my numbers? That's what I would recommend doing as step one. And then the second step is, okay, once I know that data, what do I do to my process? Do I need to make any workflow changes to make sure that my doctors can get the right code the first time without spending a lot of extra time? Right? We don't want to turn our doctors into coders. So I would recommend knowing what your unspecified rate is, and then with that data in hand, examining your workflow to make sure that it's producing the right kinds of results that you'll need to be successful. So how do you get the unspecified rate for your practice? Well, you can look at all of your coded diagnoses, figure out which ones are unspecified, which ones are not, and do the math for yourself. Or one of the things that we do for people who attend one of our webinars is we will do this unspecified analysis for you. Right? You send us your diagnosis codes and how many times they were used, and we'll send you back something that looks like this. It'll show you what the unspecified rate is for your practice. It'll show you what your denial risk is per day if your payers were to crack down on that, and let you compare yourself to other similar practices and to the national average. Right? Now that in and of itself is very powerful information, but most practices want to go a step further because they know they have some doctors who are better at this than others. So that you'll see down at the bottom of this analysis, it gives you a doctor by doctor, a provider by provider breakout that shows how well each provider is doing. Right? Now, I oftentimes get a question here about, well, what's a good unspecified rate? And are we ever going to be able to get that number down to 0? And the answer is absolutely not. You're never going to get that number down to 0. There are appropriate times to use an unspecified code, right? Some unspecified codes are probably okay. We don't know what's causing the fever, right? You use an unspecified code. But when you see a patient with knee pain and you don't know which knee was bothering them, that's one that's probably going to get you in trouble. Okay? The other part that comes with this analysis, and I think this is really helpful for the next step, is it will show you for your practice, these are the most frequently used unspecified codes. Here are the top 10, right? Right? These are your 10 most wanted list. the most common unspecified codes for your practice, so that you can start to work these top down. It gives you the unspecified code, how many times it was used, and then the available alternatives. So you can see for the first one, pain in unspecified shoulder. Well, that's clearly not going to be okay. And I should be using either that M25.511 or M25.512 instead, right? Now, you'll need to do some digging to figure out why you're using that unspecified code so many times. Is it because your doctors have memorized the new code? Is it because they built some sort of, cheat sheet that has only the unspecified code on it to save space or to make it easier? Is it because when they use the code search in your EHR, the unspecified code comes up first? Right? They type in shoulder pain, that's the first one that comes up, and just like Google, they pick the first result every time. Right? It could be any number of reasons. But you do want to make sure that you understand why and that you put a process in place to get the right code without turning your doctor into a coder. Right? If you'd like to talk more about that, if you'd like to hear kind of our ideas on how our clients are doing that so well, happy to talk to you about that. But the first step, in my opinion, is doing this analysis. Right? Okay, now I know I went through a lot of information, and I went through that very quickly. Let me summarize what we wanted to do, and then I'll try to answer a few questions for you. The first takeaway is what we started with. ICD-10 began on October 1st, right? That's when ICD-10 started. That was not when it ended, right? The proper metaphor is ICD-10 is like having a baby. Yes, the lead up to that was difficult. Yes, there were lots of things that you needed to do, but the journey begins on October 1st. It didn't end on October 1st. That's what I'd say is number one. Number two, we haven't seen the full impact of ICD-10 yet. Much of those changes are ahead of us, not behind us, right? Most of those changes are still ahead of us. So you will have to be able to respond when the payers start to make those types of changes, right? Make sure that your practice leadership hasn't taken their eye off the ball here, right? Once you get those pieces in place, then you want to make sure that you know how at risk your practice is. What's your unspecified rate? How is that going to work when the payers start to crack down? And then once you know your numbers, you can go back and look at your process and make the appropriate changes if necessary. To number one, make sure you protect your doctor's time, protect their productivity. Because if we don't do that, the rest of it doesn't matter. And then the last piece is, how do we get the right code the first time, right? So that we can prevent denials before they ever happen. And make sure that your practice is getting paid correctly and completely the first time you submit that claim. All right, I hope that that's helpful for you. I know I went through a lot of information quickly. I will try to answer as